Hello, everyone, and welcome to Talk Nerdy. Today is Monday, January 12th, 2026, and I'm the host of the show, Dr. Cara Santa Maria. And as always, I want to thank those of you who make Talk Nerdy possible right here before we dive into the episode. Remember, if you are interested in pledging your support on an episodic basis, all you've got to do is visit patreon.com/talknerdy to learn more. This week's top patrons include Resolutrial, Chuck Blell, David J.E. Smith, Daniel Lang, Mary Neva, Anu Bhadavaj, David Compton, Brian Holden, Gabo J., Ulrika Hagman, Pasquale Gelati, and Joe Wilkinson. Thank you all so much. All right, let's get into it. It's our second episode of the year. We are now at number 584. I'm in my 11th year. I started the show in March of 2014. So in a couple of months, we'll be moving on to year 12. That's incredible. So this week I have a really interesting chat for you. I had the opportunity to speak with Dr. Jonathan Mathias Lassiter. He is a licensed clinical psychologist with a practice in New York City. He's also an author, a speaker, and an educator, and he has a new book out called How I Know White People Are Crazy and Other Stories, Notes from a Frustrated Black Psychologist. So without any further ado, here he is, Dr. Jonathan Mathias Lassiter. Well, Jonathan, thank you so much for joining me today.
Thank you so much for having me. I'm excited to be here.
Me too. I was really excited, intrigued, all of the things when your book came across my desk. So it's called How I Know White People Are Crazy and Other Stories, which I absolutely love. I am a white person, and so and I can attest to the craziness of the other individuals and just the cultural craziness of sort of white nationalism in this country. Notes from a Frustrated Black Psychologist, also love just putting that out there. So one of the things I wanted to say right at the top is that I started this show 11 years ago now when I was doing full-time science communication before I had even started to go back to school and finish my PhD in psychology. All my, my undergrad and my master's was in bio. I was working as a neuroscientist for a while. But it's so interesting that over the course of doing this show for the last decade, I completed a PhD. I did an internship. I did a fellowship. I'm now licensed. I'm now practicing. But I rarely have psychologists, especially clinical psychologists, like those who see patients, on the show. And so I'm really excited to be talking to somebody who kind of has been through that and who is now practicing, and B, to be talking about these issues not from a sort of theoretical or research perspective, although we will discuss that, but really from a boots on the ground practice perspective.
Yes, I'm excited to chat about that as well. And I don't know about you, but I'm in private practice. And so sometimes it can get a little lonely. So I'm happy to be talking to a fellow clinical psychologist as well. So
absolutely. And I'm actually, I do sometimes see private pay patients, but I actually work in a really large hospital. But it's also sometimes really lonely because even though I have a lot of colleagues, my colleagues aren't psychologists. I'm sort of in a silo in a cancer center where I'm the only psychologist, and I work with social workers and with MFTs and psychiatrists and folks from other disciplines. That said, as you know, and as anybody listening who's ever had therapy knows, most of what we do is one-on-one with the patients all day, every day. And I'm remote. I work from home. So even though I have colleagues and I have, an infrastructure that I work in, which is different than you kind of having your own business, really, the bulk of our day is we are holding space for our patients, and we are working in kind of co-collaboration with our patients, but we don't always have that outlet of talking to other psychologists or talking to, that's why most of us have our own therapists, right? So we can be like, oh gosh, I need to decompress.
Exactly. I definitely know I have I actually just finished seeing my therapist about 30 minutes ago. So,
Oh, nice. So fresh. Oh, I love that. Very, very close to the surface. So, so talk to me a little bit about your background, because I think it would be helpful for the listeners to know kind of how long you've been doing this. Was this your first career? Did you know you wanted to be a psychotherapist? Like, how'd you get into it?
yeah, so I have been officially a doctor for 11 years now.
Hmm.
So I started graduate school in 2008 and I graduated in 2014. And but how do I get into this? So just have always been fascinated and curious about why people do what they do from an early age. I remember my siblings, like my parents would say, if you do A, you're going to get B. And they would do A and then they would get B and then they would be upset. And I was like, but they told you what was I'm confused as to why you're upset. And so and so that and a bunch of other confusing life events along the way really made me interested in why people do what they do, and interested in the life of the mind and mind, body, spirit. And so I just learned about this thing called psychology and decided that's what I wanted to do. So that's always really what I wanted to do is mental health. Originally, I thought I would be a psychiatrist, but then I did some shadowing of psychiatrists in undergrad, and I was like, mostly they're just doing medication management. That's not what
Mm.
I really want to do. I want to actually like learn people's stories, and so then I found out, oh, that's called the clinical psychologist, and so then I got on that path, and as I said, I started graduate school in 2008, graduated 2014, and then went into my first tenure track job. But it wasn't until this summer that I went into full time private practice, and I love
Mm.
it. Yeah.
And so tell me, a lot of people, when it comes to psychotherapy, we're going to peel back the curtain a little bit for folks who are
Yeah.
listening. A lot of people, because we have to do an APA internship to get our license, because we have to do postdoctoral hours, end up having some form of specialization or just some form of kind of a deeper interest into certain populations. And that's
Mhm.
separate from the way we might identify our orientation, sort of the
Yeah.
way we conceptualize our patients. So first, let's talk a little bit about your specialization, or if you tend to identify more as a generalist.
I definitely don't identify as a generalist.
Hmm.
So I would say in school, my training was definitely in health psychology.
Okay.
And so I did a lot of primary care psychology. So when you talk about working in hospitals and things like that, I'm
Hmm.
like, oh, I've done that. And I loved
Hmm.
it, right? I loved it. And HIV, um,
Hmm.
psychology. I have a lot of training in that as well. And so just a lot of medical psychology, a lot of health psychology is what I focused on when I was in graduate school. However, coming out of graduate school, while, that definitely still influences how I think about the mind body connection, just, seeing the need in my community for people from marginalized communities is really where I turned my attention to. So right now in my practice, I specialize in working with high achieving Black, POC, and LGBTQ plus people who are navigating life, navigating relationships. So I see both individuals and couples, and helping them navigate both those sort of emotional distress, but also that comes from family and other stressors that I would say more general stressors, but also mental health concerns that are due to societal harm,
Hmm.
and so I'm working a lot of times with marginalized communities doing that work and really integrating this mind, body, spirit, this cultural way of practicing. Yeah.
Yeah. Yeah. Yeah. That's great. That's huge. And so when we talk about this idea of sort of an orientation uh, within psychotherapy, I'm not talking about our, sexual orientation or our gender identity. I'm talking about the way that we conceptualize patients, the way that we're either trained or do a lot of self-knowledge to think about patient care. Some of the big ones that people may have heard are like cognitive behavioral therapy or psychodynamic psychotherapy, existential humanistic, but there are all sorts of subcategories like person-centered, like feminist, like intersectional psychotherapy. Clearly, you're working from an intersectional lens, but I'm curious if one of the kind of big three, CBT, psychodynamic, or existential humanistic was a training paradigm for you, or if you tend to identify in any of those ways.
Yeah, so I was definitely trained in hardcore CBT.
Like most people are. Yeah.
Hardcore CBT, hardcore evidence based, so like exposure
Mm-hmm.
therapies, because I did a lot of trauma work as well.
Mm-hmm.
And now, though, I would say I mostly am focusing on third wave cognitive therapies. So,
Mm-hmm.
integrating mindfulness, integrating self compassion into the work, but also focusing on psychological flexibility in general. So, that's the language of acceptance commitment therapy. And I also focus a lot on again, integrating culture. So there's this African centered modality, or I should say orientation, called optimal conceptual theory, that's
Mm.
also looking at worldview and how that influences mental health as well. So I would definitely say that I am much more integrative these days, but definitely my foundation are those more third wave cognitive therapies.
Oh, I love that. I want to learn more about optimal conceptual therapy. And just for the listeners, if you don't remember, if we haven't talked about this in a while, so that we can contextualize the positioning in this conversation. I was one of the kind of lucky few in the country. I consider myself lucky because of this, who had the opportunity in my training institution to really be trained in an existential humanistic lens. So although I do practice CBT, I work in a hospital, right? Like, of course, I'm going to be using a lot of evidence-based interventions. It's just not how I conceptualize patients. I conceptualize patients with a very deep kind of existential humanistic, very like Yalom informed
Mm.
lens. And then I utilize different interventions depending on the individual. And of course, I think we're all very person centered.
Yes.
I also identify as very intersectional. My concentration in my PhD training was social justice and diversity, and so that's always the lens that I'm striving to see patients through.
Mhm.
And I use the word patient because I work in a hospital,
Yeah.
but I know a lot of psychotherapists hate that word and they only say like client, or they'll even just say person.
And I switch back and forth because
Okay.
again,
Yeah.
most of my early training was in hospitals, and so I got used
Yeah.
to that patient language, and then I was like the client. I was like, oh, okay, so I actually use them interchangeably. Yeah.
Oh, I love that. I love that. And so, I'm curious if you were to, it's probably hard to say what percentage at any given time of the individuals that you're providing care for, what percentage of them are Black versus, of course, the book How I Know White People Are Crazy and Other Stories. What percentage of the face-to-face care that you're offering are with white clients, and of course there's a million other identifications in between.
Yeah.
But how would you say that your kind of case management is divided usually?
That's an interesting question. I don't know if I've actually sat down and thought about that.
Mm-hmm.
Because I do have such a diverse caseload. Let me
Mm-hmm.
see. I'm going to pull up my calendar while we speak.
Oh,
And
I
just
love it.
let's
Because
see.
I
So,
think something happens when an individual, if you're a Black therapist, Black clients are going to seek you out because there just aren't enough Black therapists, right? Like
mhm, mhm.
there's an absolute need. Obviously, if you are somebody who identifies within the LGBTQIA spectrum and you are uh, outspoken about that, you're going to have LGBTQIA individuals seeking you out because we want to make sure that the person who is providing care for us, although it's not required that they have, similar kind of aspects of intersectionality, of
Mhm.
course you want your therapist to know what you've been through,
Of
right? Or at
course.
least to get it. And so, of course, I can imagine that like Black folks are going to seek you out. But that
Mhm.
said, we are practicing in a white, almost not anymore, but like white majority country, definitely a white, uh, a sort of what's the word I'm looking for? Supremacy, country,
Mhm.
and white people tend to, from an SES perspective, by and large, have the means for things like private psychotherapy to a larger extent, which is also an issue that we're always trying to navigate as providers.
Right. 100%. And I definitely make it my priority to make sure that people from marginalized communities know that I'm here and that I do understand the background, the social historical context, et cetera, right? And I'm bringing not just my clinical expertise, but also my lived experience to the work. Um, you know, I just did the math. 45% of my clients are Black. So
Mm-hmm.
and then I would say probably a larger percentage, though, are part of LGBTQ plus communities. So I would say
Mm-hmm.
right now I'm at 20 clients, and I would say 9 of them are of African descent,
Mm-hmm.
and I would say probably about 14 of them are from LGBTQ plus communities. And then, of course, I have clients. I have about 3 clients who with immigrant backgrounds who came
Mm-hmm.
here for college and now work here. And I have about 5 women. So
Mm-hmm.
I definitely have a mix, and I love it. I love it. Yeah.
Absolutely. And
Mhm.
so, how much, I guess, I don't know, experience exposure, I don't even know what the right word is, but how much in your training and throughout your career so far have you had that experience of working with like cis het white men?
Oh, yeah. So it's interesting because I did my training, most of my clinical training, at least those early years in the Bay Area. So I was working with people from marginalized communities, Black, Latine people from low income backgrounds. But I also was working in an HIV clinic at a hospital out there, and most of those people were white gay men, and so
Mm-hmm.
cis gay men, white cis gay men.
Mm-hmm.
And so it wasn't really until I went on internship, which I write about in the book, um, at the Indianapolis VA, where I was working with all of these, like I would say 99% of my caseload were white, heterosexual, cisgender men. And so that was a very interesting experience. And it was one of the things that was so eye opening, and again I write about it in the book, and it's part of the motivation to write the book was because people kept saying to me, my supervisor would say, "Oh, I'm sorry, we don't have more diversity for you," and I'm thinking to myself, that to me that's very white centered, because it's like I
Mm-hmm.
am a Black same gender loving man who has mostly been working with marginalized communities. Like, this is diversity to me. Like, I
Mm-hmm.
think that, like, if you train in psychology, you just automatically know how to work with, white people, right? And it's just like, actually, I don't. So, this is a new community for me. So it was a really big eye-opening experience for me. And to be quite honest, I will admit my own bias going in. I was like, oh, am I going to be able to have empathy for white people? Because naive me at that time, I was like, oh, white people have so much privilege, are they going to have real problems? And again, so naive of me to think that way. And when I started to actually do the work, I was like, oh my gosh, there was so much empathy. I mean, my heart just broke, oftentimes for these cisgender heterosexual white men, because they were just so emotionally stifled in so many
Yeah.
ways, and just so used to emotional suppression, and a lot of times their trauma and their pain came out as anger. And at
Mm-hmm.
that time, I didn't always know that was what was happening. But it, thankfully, I had great supervisors and got some really good training that I was able to see. Oh, okay, so this is actually fear. This is actually depression. All of the things that I'm seeing in the communities, the marginalized communities I work with. I was like, it just shows up a little bit differently, or the language is a little bit different in this particular population. But I really enjoyed my work with a lot of those veterans at that time. Yeah.
It's fascinating, this idea. I'm grappling with this right now in my head because my, I guess, parallel experience with that, or with that question of like, can I empathize with these folks, and am I going to be able to be like an affirming provider, is working with people with like overt racist tendencies. Is like,
Mhm.
how do you sit with somebody who's either overtly racist or overtly sexist, and provide that kind of empathic care. And I think that I'm grappling with this idea in my head of like kind of holding two spaces at the same time, where let's say you as a gay Black male provider, myself as a white queer, like half Puerto Rican female provider,
Mhm.
are sitting across the table from an individual who is, for all intents and purposes, in the ruling class or in the oppressive class. But this is still a person who was raised in society and who
Mhm.
was taught from the time they were young that they were owed certain privileges, and who is frustrated and has a lot of angst about the fact that like life maybe didn't turn out the way that they were told it would for them.
Mhm.
And it's that thing where of course you empathize with the experience of somebody feeling like they have an unfulfilled life, or feeling disappointed in themselves or in their community or in their path, and at the same time understanding what privilege is, and
Mhm.
and knowing that maybe this person does not have insight into their own privilege.
Definitely not, and that was exactly my experience at the VA, and one in particular that again was really became a motivation for the book. Was this white cis heterosexual male veteran, and he would come into the work oftentimes and just say such racially charged, racially microaggressive things to me. Like one
Mhm.
time he was like, "Oh, my family owned slaves," and I remember one time he came in
Mhm.
crying, and he was like, I've learned that some of my family members owned the slave ship," and I'm thinking to myself, but you knew that they owned slaves, so I was like, what makes the slave ship so different? And he said,
Right.
well, it's because under slave ship just means that they were, enslaving these people for money. But like my family who owned slaves, those slaves were like family.
Oh
And I, was
God.
and I was thinking to myself, what?
Yeah.
Well, like, sir, do you understand what enslavement was like? I mean, it was just so out there. And then, at the same time, he was, President Obama was in the office at the time, and he was like, blame, these poor people, these Black people for,
Mhm.
everything that's going wrong, and how they're getting these Obama phones and they're leeching off the system. And I'm thinking to
Mm.
myself, sir, you don't pay for your health care.
Yeah. I know. Keep your government hands off my
Right. I was
Medicaid.
like, and there's,
Yeah.
and there's no shame in that, It's just
Right.
also like you are in the same boat with the people
Mhm.
that you are, scapegoating. Come on. But to your point, through those experiences, I that's when I first started developing this this idea of whiteness, of the whiteness mindset, because I was like,
Mhm.
there's something else going on here. This guy is not just suffering from depression. He's not just suffering from insomnia. There's something else going on here, and I think it's cultural. And it really was this sense that he had been sold this propaganda that as a white cisgender heterosexual man in America, he should have everything.
Mm-hmm.
People
Yep.
should respect him. His wife, his partner should obey him and please him. His children should be obedient, etc. Right, and he should have money and this sort of status, and he just didn't for whatever reason, right? And so I found that he would often go to these scapegoats, and he would often come to me again with this like really racially charged stuff. And I was thinking to myself, like, you see that I'm black, like what's
Yeah.
going on here? And then again, with the help of my supervisor, she was like, I think he's trying to connect, but he doesn't
Mm-hmm.
know how, because you go against everything that he believes about black people.
Right, which is the beginning of like racial identity development is that early stage where when somebody has racist attitudes, they're like, but you're the exception to the rule. And then they start to learn, wait a minute, maybe what I was taught is not actually a reality.
Exactly. And I think part of his whiteness mindset was trying to sort of right the quote unquote wrong, right? Like he was supposed to be on top in this dynamic,
Mm-hmm.
right? He's a white man
Mm-hmm.
talking to a black man. He's supposed to be on top, but in a lot of ways, because I was the mental health care provider who he was coming to for help, I was the
Mm-hmm.
one on top, right? And so he would then bring in these racist things to sort of kind of level that playing field. And so I just started to see that, like, oh, this is a whiteness mindset. Like there's this us versus them mentality. There's this kill or be killed mentality here. And he is really trying to work this thing out at this unconscious level. I don't think he was doing any of this consciously.
Oh
You know?
yeah,
Um,
I wouldn't think he would either. And I think
yeah.
there's this interesting dynamic at play that is so difficult for the therapist, who is a human being also, albeit one with training and with capacity to hold this kind of space, where you've got an individual who, on the one hand, and I've many books, many conversations with all of my intersectional friends and supervisors over the years. A lot of soul searching myself has brought me to an understanding that what a lot of white men, especially like cis het white men, are dealing with right now is a not even disenfranchisement isn't the right word. It's a uh, it's it's an ennui that comes from recognizing that the bill of sale, right, that they were sold, the expectations that they were supposed to get, they aren't getting, at least from a socio-financial perspective. Basically, they're experiencing life that women and Black folks have always experienced,
Mhm.
which is that they don't, just by virtue of their gender or the color of their skin, get a pass.
Mhm.
They don't just get a leg up simply by virtue of that. And even though they still are getting a leg up from, a systemic perspective, from an institutional perspective, we do see these economic difficulties in like Rust Belt states. Now we're seeing it across the nation, where white folks, especially white men, are saying like, "Wait a minute, I did everything right. I went to college. I saved up and I did the thing. And why don't I own a home? Why don't women like me? Why couldn't I get married? You've got the male loneliness epidemic, which I think
Yeah.
is just another version of this. And so now you're in a position, I think about like white women's tears, right? You're in a position where he's recognizing the horrors of his family history, and he's dealing with the guilt that comes along with that and the shame and the pain. Yet he needs you, his Black therapist, to comfort him and hold
Mhm.
space for him through that. What a position to put you in, because now it's a dual role, right? If you were his friend, if you were his Black friend, it would be like, no way, talk to your white friends about this. This is not my place to be the guy who comforts you. But you're his therapist. So what do you do?
Yeah, well, at the time, I did not have the training. And again, this is something that I write about in the book, is that I think
Mhm.
as a field, we do a poor job of training therapists how to deal with these types of dynamics. Again, most of the social justice or diversity training, if you will, in psychology, it really has a white audience in mind.
Of course it
Um,
does. It's It's don't sit higher than your black patient. Don't make them feel like you're not at their level. It's not the other way around.
Exactly. And so when you have this sort of dynamic, I was definitely not prepared for it. And again, I didn't really know what I was looking at. And so I think, I went really relationally, right? I was like, okay, so tell
Mm-hmm.
me why is this important for me to know? Things like that,
Mm-hmm.
right? To really try to get to the depth and to really try to understand and lean into that empathy, because
Mm-hmm.
otherwise, I mean, again, as a human being, in the back of my head, I was like, what the F, like, why,
Yeah, yeah.
like, like, what's wrong with you, and then, or then, but in the forefront of my brain, I was like, okay, you're a professional here, like this means something, like figure out what it means, go lean into the empathy,
Mm-hmm.
so I really went relationally, but what I really realized at that point was that my training was insufficient when it came to these
Mm.
types of issues. Yeah.
Yeah, yeah. And so that's where I think the benefit of, in some ways, the sort of practitioner scholar model, right? Those of us who did PhDs, some folks who are practicing clinical psychologists did PsyDs. And I think you get a little more of it in PhD programs, but not always, because every program is different. Some PsyD programs offer this as well. But definitely at the doctoral level, you are doing the work to fill in the failures and the gaps of the entire institution, right? Of psychology as a field, which has horrifically racist roots. Like it dates, psychology developed in lockstep with eugenics. We know some of the quote greats in the field were like total eugenicists, even things that we think of as divorced from sociocultural influence like statistics. All of the statisticians that are celebrated were setting out to prove the superiority of the white race. Like that
Yep.
that's what they were doing. It's
Yes.
totally gross.
Mhm.
Yeah, when you dig into it. And so the field itself is fraught. You have supervisors who themselves are perpetuating things because they weren't trained through, lenses that took them outside of their own comfortable viewpoint. So you as a practitioner scholar were tasked then with doing the work yourself, with going, there got to be people out here doing this research.
Mhm.
There is a literature, there are other people who I can talk to and learn from, and I can contribute in this way. My own experiences are important to inform other people.
100%. And that's really what led me to African centered psychology.
Mm,
So, as you said, there definitely have been people who have been doing this work and trying to think about what it means to be human from a more holistic perspective, and from a
mhm,
more ancient and culturally grounded and indigenous perspectives. And so African centered psychology has its academic roots in the United States in 1968 with the formation of Association of Black Psychologists. However, those psychologists themselves are drawing off of the ancient history of a multitude of African societies and communities, and the ways in how they think about what it means to be human, and for a lot of them that was meant to be a spirit having a physical experience, this energetic
mm,
life force that's never ending, which it's in stark contrast to this belief, this annihilation assumption that a lot of that whiteness tells us, right, that we're at risk of destruction all the
right.
time, whether physically or metaphorically, or ideologically. And so when I learned about African centered psychology, I said, "Oh my gosh!" Like these theories make so much sense, not just for me as a person of African descent, but for me as as a human being, right? And why haven't I learned these things? And it goes
Mhm,
back to the Eurocentricity of psychology education. And I think that's something that is often not discussed enough. I think it's starting to be discussed in some circles, but it's definitely not discussed broadly in psychology, around just how what we are taught as psychology is actually European
yeah.
ideas about the mind. It is not a
Mhm,
universal thing, but we are fed those European ideas as if they are universal, as if they are one size fits all. And that's just not the case.
Absolutely. And so, I'm curious, coming back to sort of the title of the book, because of course, although it is 100% an accurate title, it's also a title that grabs people's attention, right? And makes them go like, what are you trying to say here? How I Know White People Are Crazy and Other Stories, Notes from a Frustrated Black Psychologist. Let's talk about that. Even just the term crazy is a pretty confronting word
Yeah.
from a psychologist, but
Mhm.
this is intentional, right? So tell me about your thought process there.
Very much intentional. And so, part of what I learned in this process is that as an author, I not only have to write the book and engage deeply, in this intellectual process, which the book is definitely an exercise in intellectualism and emotionality, because I really
Hmm.
wanted the emotions to be palpable when people read the book. Um, I also had learned about marketing.
Yeah.
And so, yeah, the title is definitely meant to get attention. It's also something that I heard my father say often, growing up
Mm,
in 1990s Georgia. My father would come home from his job at doing pest control, and he would, be responsible as one of the most senior people in the company. He would be responsible for training the new recruits, and it would often be these young white men, and then these young white men would get hired, oh, excuse me, they would get promoted ahead of him. Meanwhile, he's been
yeah.
there longer. He has more of the expertise. He understands the business better, right? He has better relationships with the clients. But racism, was like, oh no, this white guy is the supervisor. We're not going
Hmm.
to have this black guy supervising these white guys. And so my dad would say, boy, these white people are crazy. Um, and as I start to move through my own professional journey and just to start to live life more as a black man in this country, I also realized, oh wow, these white people around me are really crazy. They really just don't understand how limited their worldview is, and they don't understand how they think about the world through this mindset of there's not enough to go around, kill or be killed, us versus them, how that is harming them as well. And so my definition of crazy is when we continue to do something that harms us. And
Hmm.
so I really when I was thinking about the title, I was like, I think that's a really very appropriate title. How I Know White People Are Crazy, because I've been up close in these training settings, in these professional settings, in these clinical settings with a lot of white people who are really suffering because they're trying to hold on to the propaganda of what it means to be white instead of embracing what it means to be human.
Ugh, I love that you use that word suffering because, I mentioned earlier that one of the things I often wanted to bring up in my own training and with my own supervisors and with my peers, and sometimes it was sort of accepted and encouraged to engage in these kinds of conversations. And other times it was like, yeah, we're not quite there. Like, we got to stick with, we're just working on basic identity development. Was
Mhm.
this idea of like, I love ethical conundrums. I love getting into the deep gray area. Like, at what point is this okay? At what point is this an ethical concern? When working with somebody who is espousing racist or sexist views or transphobic views, or, like, add the ist there, at
Mhm.
what point is this idea of like this Rogerian person centered, unconditional positive regard, meet this person where they're at, which is such a huge part of our training? At what point is it actually detrimental to sit in that space with somebody? Is it not psychologically damaging? Is it not actually an indication of poor psychological health, poor mental health to espouse racist or sexist views? And is it not our role? Because very often, right, like, I'm an atheist, but I work in cancer. So I work in end of life. I have a lot of patients who have a lot of different religious views. It is not my job to in any way undermine their views about end of life. I am there to understand or to try and sit with where they come from and to try and meet them where they are and to try and work within their mindset, right? I'm working with somebody who's Muslim. I'm working with somebody who's Christian. They believe in an afterlife. I am sitting in that space with them and operating under their assumptions while I'm offering them psychotherapeutic support in the end of life. I'm not going, well, have you thought about maybe if there wasn't a God? That is not my job, right?
Right.
But parallel structure, have you thought about maybe that, women are equivalent to men? Like, it is actually not the same thing. And I think often it's taught as if it is the same thing. It's just some other aspect of intersectionality. But my view has always been being racist is not psychologically healthy.
No, it's not. It's psychological rigidity is what it is, right? And
Yes.
any form of psychological rigidity is where we get into trouble, right? It causes mental health problems. And so, I often think about it as like, what's I do a functional analysis. What's the function of this? What do you get out of this? Right. And how is this serving you? And to point out that rigidity. I do not consider myself an unbiased therapist. I'm not. I am an anti-oppressive therapist. I am an intersectional therapist. I believe in grounding culture in my work. I'm not a blank slate therapist. And
also, spoiler alert, nobody is.
Right, exactly.
They might say they are, but they're not.
But I don't even try to pretend, I should say.
Right. Yeah.
But yeah, I lead with my belief systems, right? Like, you go to my website, it says culturally informed therapy and mental health services, right? I'm letting people know up front, if you're coming to me because you want someone who is going to call a thing a thing. You're coming to someone who understands the role of culture, of intersectionality, and how that intersects with all parts of our health. So I am definitely not unbiased person, and I don't try to pretend to be an unbiased person. And I will call out my clients' bias and their psychological rigidity. Whether it is about a particular ism or is it about their how they view themselves, their own self-image. So that is definitely something that I'm like, hey, listen, you come to me, get ready.
Yeah. And I think that's one of the great privileges of being postdoctoral. Like, once you are licensed, you are in a position where you can position yourself as a provider and really, like, even kind of market yourself as somebody who practices from a perspective or from a lens, or who is a safe space for certain populations. One of the difficult things, and I mean, you write about this beautifully, it's kind of been the bulk of what we talk about, is that sometimes in our training, we find ourselves in positions where we have to kind of navigate those things a little bit more carefully. We have supervisors who have their own blind spots. We work for institutions who think that they're being anti-racist, but really what they're being is colorblind, which is a form of racism. And that's a tough thing. Like, even me, like, I'm, I work for a large institution. I'm very lucky that I work for a large hospital that was founded on Jewish principles. That's incredibly, like, LGBTQIA affirming and incredibly promoted to social justice and diversity. So for all intents and purposes, I can also be similar. I can position myself from a strong intersectional perspective, and none of my supervisors have a problem with that. But a lot of people who work in institutions don't have that privilege.
It's true. They really don't. And especially with the current administration, who's not just discouraging it, but are attacking people who would say so, and dismantling those programs. Again, though, that does everyone a disservice, not just those people from marginalized communities, but it's also is doing those people who we might think of as privileged a disservice, because, again, privilege has a lot of great things attached to it. It can also be a box. It can also be a
Hmm.
box. It can also be a coffin, if you will. Because in order to hold on to privilege, sometimes, depending on what type of privilege it is, it requires you to kill parts of yourself. It requires you to look away from the injustice that is done to you and done to others. And so it really is a disservice to everyone when we choose not to take on that intersectional lens, when we choose to ignore oppression in any form that it may be.
Yeah, yeah, I agree wholeheartedly. And so, what is your approach? I mean, we've all kind of studied like Sue and sort of the individuals that are at the core of the like diversity training that as you mentioned was, and it's interesting too because Sue and Sue are Asian,
Yes.
but again, that sort of like whiteness perspective that we're often taught from. I think in a way they were like leaders in trying to get outside of that, but of course, there's so much more depth now. Um, how do you go about when you have trainees, for example, or when you are working towards trying to improve insight among your colleagues to help individuals get outside of that sort of white normative perspective?
Yes, and yes, shout out to Sue and Sue.
Yeah.
I think it was our first introduction to a lot of us. But yeah, no, for me, I try to be much more culturally specific.
Mhm.
There are times, as a professor, of course, I've taught multicultural psychology, so it's more of a broad strokes and things like that. But when I would be training my PhD mentees, I took a culturally specific approach, and for me, that's again that African centered psychology. And so I'm looking at the works of people like Dr. Linda James Myers, who talks about optimal conceptual theory and about how health is tied to an optimal worldview that again sees the connection between the visible and invisible, a worldview that prioritizes healthy relationships over materialism, etc. I'm looking at the work of Dr. Wade Nobles, who talks about conceptual incarceration, in which looks at how people, even when they're trying to think outside of the box, are sometimes still confounded by their oppressors' ideas. I'm looking at the work of Dr. Kobe Cabone, who talks about cultural misorientation, about how when people sometimes take on the characteristics and roles and traits and ideologies of their oppressors and how it harms them in doing
Mm,
that. I'm thinking about the work of Dr. Cheryl Grills, who talks about emotional emancipation circles as a way to really dive deep into one's emotions and the use of somatic practices to really process emotions. I'm looking at the work of Dr. Joy DeGruy, who talks about intergenerational trauma through the lens of slavery, this post traumatic slave syndrome. So I'm looking at very specific scholars to move beyond that Eurocentric idea, in addition to people who talk about intersectionality, like Dr. Lisa Boleg and others. And you know what? I'm also moving beyond psychology. I'm also looking
mhm,
at
yeah.
fiction. That's one of the things I often encourage my students to do is like, don't stay in the silo of psychology because there are poets, there are novelists, there are sociologists who have been talking about this stuff way longer than psychologists have been. So, reading the work of bell hooks, um,
Mhm.
I think it's important for mental health training. Reading the work of Alice Walker, Toni Morrison, is so
Yeah.
important for mental health training because it really does help us understand how to be a more holistic, uh, collectively engaged human being. Reading the work of James Baldwin, when Baldwin says that we can't hold on to our humanity if we are assaulting the humanity of others. That has real implications for mental health. And so that's how I move beyond this whiteness centered understanding of diversity, equity, inclusion, and all those things, is that I'm like, no, let me go to people who are specific and not trying to speak to a broad audience. Because here's the thing, regardless of the culture, there are there are things to learn, right? And it's about how do we try those things on, what fits, what doesn't fit, what do we keep for ourselves, what do we let go, right?
Mhm.
And so that's the way that I approach that.
I love that. And I'm curious for your take on something. I'm going to bring up a personal experience during my training, and I
Mhm.
would love to, I love that you've been so open and honest about, like, at that point in my development, at that point in my training, I didn't have the insights that I have now, and this is how I handled it then. This is maybe how I would handle these kinds of things now.
Mhm.
I had an experience, and it wasn't that long ago, a few years ago, when I was in Florida. So, right there, that tells you a lot. I did my internship at a private university psychology center in Florida, where we weren't treating the students of the school, we were treating an outpatient clinic. I specialized in, at the time, geropsychology. Um, and but the other trainees in our clinic, I was lucky enough to have an existential supervisor, and she was amazing. And we had a clinic that was, I think, almost all women at the time, but they were mostly white women who were providing services. And we had a book club, and each month a different trainee. So again, I was an intern, which, for those who don't know, that's your final year of your PhD when you're also finishing your dissertation, where you're working full time for a year. And then I was, co-supervising earlier trainees, so second, third, and fourth year psychology graduate students who were also seeing patients. And then we both had a licensed psychologist, not both, we all had a licensed psychologist who was supervising us. Again, my psychologist was existential. She was very intersectional, and she was a wonderful person to work with. Each week or each month, a trainee would bring a different book, and we would dive into it. So one month, somebody chose the book, So You Want to Talk About Race. We all read the book together, and then we discussed it. And there were a couple of students whose reactions were as expected, but they would say things like, "This is not the way to get through to a white audience. Don't blame and shame us. It's just going to make us not listen."
Mm. Mhm.
And my professor, who I really admire, was very patient and very empathic and very slowly holding space. And I struggled with, you're already seeing patients. You are too far behind this process. You need to catch up.
Mhm.
Like, I really struggled with these students where I was like, that is not the way. Like, that's an identity development you should have been dealing with in undergrad. Right now, you're working with clients, and it worries me that
Mhm.
that's your perspective while you're working with clients. But my professor was like, hey, all of these students are on their own journey. And I was like, hey, I don't care, because they're seeing patients. They need to catch up. And it was a really tough, I don't know, I struggled in that moment. And I'm curious if you've had experiences like that, where you look to your colleagues or you look to trainees and you go, uh-oh, I don't think they should be seeing patients yet because they haven't done the work.
Oh, 100%.
And yet they still have to, because that's part of the training, right? Like, how
Exactly.
do you work on your own patience and your own sort of empathy for those trainees in that moment?
Yeah, I have to right size my expectations,
Mm-hmm.
and it's like, okay, what is my role here and what are my expectations? What do I have influence over, and what do I not have influence over, right? And focus my energy where I do have that influence. So yeah, I've definitely have had students who I had one student who was working with this gentleman in a neuropsychological rehab, and uh, the supervisor was trying to he had suffered from a stroke, and the supervisor was trying to get him to change his diet. And the gentleman was saying, this black guy, the gentleman was saying, you know, um, my diet isn't the issue. It's the stress. I'm working on these jobs. I'm a black man in
Mm-hmm.
America, and the training, the treatment staff was all like, oh, yeah, but he's eating this high caloric food. It's not healthy for him. He's going to make him more risk of stress. And so I'm doing group supervision. They have the supervisors at the site, the students do, but then I'm doing group supervision with them. And so I said to the student, I said, why aren't you listening to him?
Mm-hmm.
He's telling you what the problem is. The problem is that you all think you know better than him about his
Right.
life.
And you're not living his life.
Exactly. And so, and it was that moment I was like, wow, like these people are real. And, and this is just one example, but this is how they think on a regular basis, right? Luckily,
Mm-hmm.
I was able to get through to the student. And the student actually went back and shared what I had said to the supervisors, and they actually ended up modifying the treatment a little bit. So that turned out well. But I was just thinking to myself, oh my gosh, like this person is telling you, like why,
Yeah.
like everyone's always talking about, even before the language of DEI, it was still about meeting clients where they were, right? I was like, but in this case, you are not. You know better than this person. How dare you? What hubris, right?
Mm-hmm.
And this is what causes harm. So I have definitely been there. And in those cases, depending on what role I'm in, in this particular role, I was an instructor. So my job was to, you know, uh, was to agitate um,
Mm-hmm.
this student's way of thinking and say, okay, this is how you're thinking. What other ways are you thinking? What could be some of the outcomes of this? What are different paths that you might take? And so it was much more process oriented. However, to your point, I was concerned about that client. I was like, oh my God, like she's going to go in there, this in tomorrow with this client, and what's going to happen.
Yeah.
And
And that's sort of the thing, especially if we are the supervisor, because it's our license that's on the line.
Mhm. Exactly. I mean, in this particular case, I was the practicum course instructor, so it wasn't my license.
Yeah, and same. I was an intern, so it wasn't my license either. So I
But,
was able to
but
be
if
like,
it
you
was
know
my
best,
license,
Yeah.
but if it was my license, oh, I would have been much stronger. I would have been like, oh
Hmm.
no, this is
Yeah.
what you're doing.
Yeah, I mean, and that leads me, I guess, to what I guess is maybe the most important question here, which is who is your book for, and at what level? Like, is this for folks who are not in the mental health field but are seeking mental health support? Is this for folks who are early career psychologists who are interested in digging deeper? Do they have to be at a certain level of like identity development to be able to hear the messages that you're saying? Or do you feel like you're really speaking to folks no matter where they are in the process?
Well, the goal, what I hope I'm
Mm-hmm.
doing is I'm speaking to people regardless of where they are in the process. And one of the ways that I try to do that is it's very story heavy. That and other stories is intentional. So it is very story heavy. I'm telling about my life and my journey of becoming part of that less than 1% of Black men who are psychologists in the United
Mm-hmm.
States. I am sharing the stories of my family, of my clients, of myself, of my students, and how the whiteness mindset has impacted us all. And I'm being very vulnerable about my own emotional processes in the book. And so the book again is very much emotionally provocative. Is an emotionally intense book, and that is on purpose because as intellectual as we all can be, we know that when we touch people's emotions, that's
Mm-hmm.
how we really touch their hearts, right? And then they can start to open up and hopefully move beyond their comfort zone. And so the book is really for anyone who is interested in emotionally driven stories that are going to teach you something, that is going to challenge you to think about not just mental health, but also the world and yourself in a different way, that is going to challenge you to think about, oh my God, here's what I thought I knew about mental health and about the world. But oh my God, that's been limiting me. How might I move beyond that?
Mm-hmm. Yeah. Oh, I love that so much. Gosh, I could continue this conversation for hours and hours, and it's unfair because I've already kept you beyond when I said that I would.
No, I'm
I
enjoying
can't.
myself.
Yeah, it's been, I mean, such a joy, so insightful, learning so much, inspired and really challenged. Everybody, the book is How I Know White People Are Crazy and Other Stories, Notes from a Frustrated Black Psychologist by Dr. Jonathan Mathias Lassiter. Jonathan, thank you so much for being here with us.
Thank you so much for having me.
And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.